Hi everyone, my name is Natalie Chaser. I'm a nurse practitioner student at Palm Beach Atlantic University, and today I'm doing a case presentation focused on type 2 diabetes mellitus with hyperglycemia. A 68-year-old African American female came into the office today stating, "I've had blurry vision for about a week." Her initials are GZ and her insurance is Care Plus HMO. The patient states the blurry vision or change in vision started a week ago, ongoing, and remains at all times of the day. She mentions that nothing helps to reduce the vision change. GZ also states she has increased thirst, she urinates 2 to 3 times a day, and has nocturia over the past 2 weeks. She also states she's recently been having mild incontinence. Patient states bilateral lower extremity burning or tingling sensation that started about a week ago. She states the pain is about a 4 out of 10 intermittent and the burning tingling that's ongoing and it happens randomly at all times of the day. The burning pain starts at any time of the day without any factors causing it, she states. The alleviating factors of pain are rest, ice, elevating extremities, and a leave. Patient mentioned feeling fatigue and generalized weakness for the last 2 weeks. She also states today in the office that she's feeling dizzy and very lightheaded. She stated that 2 weeks ago she went to see her nephrologist for her new diagnosis of chronic kidney disease stage 3, and that the doctor discontinued her metformin 500 milligrams BID without the addition of a new medication. The review of symptoms. The patient admits to fatigue and generalized weakness. She denies fever, chills, nausea, vomiting, night sweats, diaphoresis, and any weight changes. She admits to having lightheadedness, dizziness, and change in vision, but she does deny any loss of consciousness, headaches, confusion, pain, and/or trauma to the head. Neurologically, she admits to burning, tingling sensation of bilateral lower extremities. She does deny syncope, slurring of speech, focal weakness, neck stiffness, decreased sensation and/or numbness to the upper extremities. The eyes, patient admits to blurriness and change in vision acuity. She denies any itching, excessive tearing, discharge, and/or pain. Ears focus exam. The patient denies any hearing loss, vertigo, tinnitus, itching, discharge, and/or pain. Nose, she denies rhinorrhea, stuffiness, sneezing, itching, epistaxis, discharge, and/or pain. Mouth and throat, the patient denies sore throat, swollen lymph nodes, bleeding, discharge, hoarseness, voice change, any pain, sputum production, cough, itching, and/or white exudate. Cardiac review of symptoms. Patient denies chest pain, palpitations, claudication, leg edema, murmurs, orthopnea, proximal nocturnal dyspnea, and/or dyspnea on exertion. Respiratory-wise, the patient denies any cough, shortness of breath, pain on inspiration or expiration, wheezing, hemoptysis, clubbing of fingers, sputum production or agitation breath sounds. Skin, the patient denies any itching, lumps, rashes, wounds, bruising, petechiae, purpura, discoloration, or sores. GI, patient admits to polydipsia and polyphagia. Patient denies any indigestion, incontinence, diarrhea, bleeding, changes in bowel movement, dysphagia, constipation, and/or pain or discomfort. GU, patient admits to mild urinary incontinence, urgency, nocturia, and polyuria. Patient denies any dysuria, lesions, discharge, hematuria, and/or pain. The patient states that she started menopause at the age of 60. Breast, patient denies any skin changes, discharge, bleeding, pain, masses, and/or lumps. Musculoskeletal, patient denies any pain, joint pain, abnormalities of range of motion, arthralgia, instability, unsteady gait, redness, or swelling. Psychiatrically, patient denies any stress, anxiety, depression, memory deficits, and/or mood changes. Vital signs: the patient's blood pressure was 138/80 while she was sitting down. Her pulse was 72, her respiratory rate was 18, her temperature was 97.1 Fahrenheit orally, her pulse ox was 98% on room air, her height is 60 inches, her weight is 163 pounds, her BMI is 31, and her pain, she denied any pain at the time of the visit. Laboratory-wise, she had no recent lab results in the past 6 months. She denied checking any blood sugars at home for her type 2 diabetes, and her blood sugar when checked at the office was 544.
Did the nephrologist even check the blood sugar in the office before stopping the metformin?
The patient's current medication regimen when she came into the office was Norvasc 10 milligrams oral daily for hypertension, Losorin 100 milligrams oral daily for hypertension, Plavix 75 milligrams oral daily for cardiac stents and ASHD, Crestor 40 milligrams oral daily for hyperlipidemia, aspirin 81 milligrams oral daily for cardiac stents and ASHD, chlorothiazide 25 milligrams oral daily for hypertension, Coreg 12.5 milligrams orally BID for hypertension, and doxazosin 8 milligrams orally daily for hypertension. The patient's allergy, she states, is she has no known drug allergies. The patient's past medical history consists of diabetes mellitus type 2 since 2010 is active, hypertension since 1999 that's active, hyperlipidemia since 2015 that's active, chronic kidney disease stage 3 since 2017 that's current and active, and ASHD which since 2012 and that's active. The patient's past surgical history consists of 2 cardiac stents to LAD and the RCA in 2012 and 2013. The patient states a family history of diabetes mellitus type 2, stroke or CVA, and hypertension. She refused to elaborate into details during the visit. The patient's social history: she denies any tobacco, drug, and alcohol use. She has been married for 30 years and has 2 children, a daughter and a son, and has 1 grandchild. The patient is retired and lives in a single-family home with her husband. She says she is only sexually active on occasion with her husband and that she has been in menopause since turning 60 years old. She states exercising about 1 to 2 times a week, but not very rare that she exercises. She tries to eat a healthy diet as much as she can and does have a normal sleep pattern. The patient's physical examination: in general, she appeared in no acute respiratory distress. She's well groomed, hygiene was good, normal affect, and she appears her own age. Head and neck: she had a normal cephalic head, normal hair distribution, no scars or bumps, no deformities, no lymphopathy. Her trachea was midline, and her cranial nerves 5 and 7 were intact. Her eyes: she had decreased bilateral visual acuity when tested. She had perla, no discharge, no icterus, normal sclera, no papilledema, no AV nicking noted, normal extraocular movement. Her cranial nerves 2, 3, 4, and 6 were intact. Her ears, she had normal hearing bilaterally, negative Ryan and Weber test, no tinnitus, tympanic membrane pearly gray, no pinna tenderness, and her cranial 8 was intact. The nose, she had no nasal discharge. It was patent in midline. Her throat and mouth, the teeth were intact, no erythema, no sores. The gag reflex was intact. The uvula and tongue was midline, and there was no swollen lymph nodes, and her cranial nerves were intact as well. Cardiac-wise, she had S1, S2, regular rate and rhythm, no murmurs, rubs, or gallops were noted, no JVD, her capillary refill was less than 3, no edema was noted, her radial pulses bilaterally were 2+, and her dorsal pedis and her posterior tibial pulses bilaterally were +1. Respiratory-wise, she had normal tactile fremitus, cleared to percussion, clear to auscultation, no adventitious sounds were noted, and present breath sounds were in all quadrants, and there was no wheezing noted. Abdominally, she had soft, non-tender, non-distension, normal bowel sounds in all 4 quadrants, normal percussion, no hepatomegaly, no splenomegaly, and no pruritus noted at the time. The skin was warm, dry, and attacked. No scars, bruises, rashes, masses, lesions, wounds, or sores were seen. Neurally, she's awake, alert, and oriented ×3 to person, place, and time. Her Glasgow Coma scale was 15. She follows commands. She has normal memory, normal repetition, no aphasia, no dysarthria. Musculoskeletal, she had normal muscle tone, normal range of motion, bilaterally, in the fingers, hands, wrists, arms, elbows, shoulders, neck, hips, legs, ankles, and toes. Her strength was a 5 out of 5 bilaterally in upper and lower extremities. Her cranial nerves were intact, but she did have a complaint of burning, tingling sensation in the bilateral lower extremities, and she had full sensation of bilateral upper extremities, and she had a normal gait when walking. The primary diagnosis for this patient was type 2 diabetes mellitus with hyperglycemia. Related to her AccuCheck or blood sugar check at 5:44 during the office visit, her complaints of dizziness, blurry vision, polyphagia, polydipsia, and polyuria, the big 3 Ps of diabetes, nocturia, mild incontinence of urine, her urgency for urination, her bilateral lower extremity burning and tingling, her complaint of fatigue and generalized weakness. Other diagnoses also addressed during the visit was her chronic kidney disease stage 3, her history of ASHD, and her hypertension. Differential diagnosis for this patient could have been Cushing's syndrome, acromegaly, glaucoma, and hyperthyroidism. The patient was sent to Aventura Medical Center emergency room for acute care setting treatment due to the severity of signs and symptoms and the blood sugar being extremely high at 5:44 when checked in the doctor's office. The patient's metformin 500 milligrams POBID was discontinued by the nephrologist 2 weeks ago due to her new diagnosis of chronic kidney disease stage 3. The patient needs the addition of a diabetic medication back into her regimen upon discharge from the hospital with the collaboration of the nephrologist. One medication that came to mind could be Tradjenta 5 milligrams PO daily. The patient is also to continue her current medication regimen for her hypertension, ASHD, cardiac stents, and hyperlipidemia.
Natalie, Tradjenta seems like a really good option for this type of patient, as there's no specific contraindications or precautions to look for in patients with chronic kidney disease. Another thing is that just something that would be good as far as assessment as the NP is, of course, to monitor the hemoglobin A1C, but that apparently, according to the Davis's drug guide, this medication can cause an increase in uric acid levels. So I don't know the significance of that in this patient necessarily, but that's something to think about. And then just that the side effects to consider and to weigh the benefits and risks of taking this medication.
The non-pharmacological treatment plan for this patient is educate about the importance of the medication regimen, healthy eating, exercise, and weight loss. She should eat regular meals and snacks, limit her protein intake, have a high fiber diet, and a low calorie glycemic index. Also educate about the importance of taking medication, all of her side effects of the medication, and the reason for each medication being prescribed. She's also made aware about keeping her blood pressure below 140/80, or even better, below 130 systolic blood pressure. She's also referred to an endocrinologist for further follow-up to help with her medication regimen, to help keep her out of another hyperglycemia incident. And the patient's family is given an AccuCheck machine to make sure the patient checks sugar on a regular basis. There is no required diagnostic testing at this time due to the patient's need for acute care for severity of signs and symptoms. A blood sugar test was done in the office and was found to be 544. Upon follow-up after discharge from the hospital, the patient will have, for continuing care, a CBC, a CMP, a lipid, a TSH, a T4, a T3, and an A1C completed. She will also have an AccuCheck done to verify that her medications at that time is working, and also an EKG. Some primary prevention guidance. The patient was educated about checking her blood sugar and blood pressure on a regular basis to track medication effectiveness, educated about healthy diet options and regular exercise regimens, and immunization regimens for clients over the age of 65 years old. Secondary prevention. She was educated about regular visits to the podiatrist for her diabetes, her ophthalmologist for the diabetes, an endocrinologist to keep her diabetes under control, and a nephrologist for her diabetes and her chronic kidney disease type 3, stage 3. She's also educated about getting an annual pap smear and a mammogram, and for a patient over the age of 50, it's also recommended that she gets a colonoscopy. The follow-up plan, the patient and her husband were notified to follow up with the office as soon as she is discharged from the hospital within that week of discharge. She's also notified to follow up with the nephrologist and endocrinologist upon hospital discharge to verify the medication regimen to allow not to have another hyperglycemia attack like this incident. The American Association of Clinical Endocrinologists and American College of Endocrinology Clinical Practice Guidelines for Developing a Diabetes Mellitus Comprehensive Care Plan 2015, or the AACE-ACE guidelines. Some of the recommendations from these guidelines was to keep the patient's A1C equal to or below 6.5 with medications, to help keep her blood pressure optimally at 130/80, because she is a high-risk patient for cardiac risk factors, to keep her, and she already has a cardiac history, to keep her LDLs below 70 and her triglycerides below 150. And they said to also, with her history, to make sure that she needs a statin with her cardiac history, as she has with her Crestor, to have a weight loss of 5 to 10%, to continue her aspirin because of her cardiac history, to have a healthy diet regimen such as the DASH diet, exercise daily, and have lifestyle modifications. They also recommended for her hypertension and her diabetes to have her on an ACE or an ARB, or a calcium channel blocker, diuretics, and alpha adrenergic blockers, which she's on all of these medications for her hypertension, and to also consider a DPP-4 inhibitor like Tradenta, for it is considered safe to be used for diabetes with a patient with chronic kidney disease. The research article I chose is titled, "Is there evidence of any safety differences among DPP-4 inhibitors in the treatment of people with type 2 diabetes mellitus and reduced GFR due to chronic kidney disease?" The patient in this case study has type 2 diabetes mellitus, and in the guidelines previous slide, it stated that the use of metformin as the patient was on, that the nephrologist discontinued, shows that it is not safe to use with chronic kidney disease patients. Studies have shown that actually the DPP-4 inhibitors are better for the treatment of patients with type 2 diabetes that also have chronic kidney disease. And in this research, it elaborates showing that type 2 diabetes mellitus is a common cause of chronic kidney disease, and that there is only a limited amount of treatment options to control blood glucose for patients with CKD. And those are insulin and the DPP-4 inhibitors. The DPP-4 inhibitors are oral, they're glucose-sensitive treatment options. They decrease the risk of hypoglycemia for patients and the extra comorbidities for these types of patients. They also help with research is shown that they do not further decline the GFR rates for these patients. So it actually is safe for patients with chronic kidney disease. And so far in research, it's shown that these patients that have taken with chronic kidney disease this type of medication class had good efficacy and tolerability of these medications. And actually, the only medication, Trugenta, in this class at 5 milligrams orally daily, is the only medication that does not need to be renally adjusted. The other types of medications in this class have to be renally adjusted to how the GFR rate is going. The role as a future nurse practitioner and a nurse practitioner student, as in the assessment aspect, for example, is to do a full head-to-toe assessment, to do a complete and thorough history and physical of these patients, to get the full picture of what is going on, to get the proper diagnosis and treatment plans. A workup could be, like with this patient, to do a stat blood sugar check to verify that the findings that you saw in your history and physical, stating the blurry vision and the 3 Ps of the diabetes, hyperglycemia, is to do a stat blood check to verify your suspicions. And the collaboration is to send this patient, for example, to the hospital for acute setting, but to also have the patient follow up with a nephrologist and an endocrinologist to give the best treatment plans to make sure that you preserve her kidney function, as well as make sure she never has an issue with hyperglycemia attacks again like this incidence. So having those specialists on board is very crucial for this type of patient. And also with the management is to make sure that she starts this new diabetic medication and is tailored towards reducing the hyperglycemia and to preserve her renal function. And to make sure, as part of your management example, is to educate about lifestyle modifications and about the medication regimens and the type of side effects she may experience and what to look out for. And to also educate her next time that she has these types of symptoms, instead of waiting 1 to 2 weeks to come in to see us, to make sure that she goes right away, checks her sugar, and comes in to get immediate treatment and care. And to also make sure that she knows to follow up routinely with all the doctors, and to get routine lab work to keep an eye on all of her electrolytes and her blood glucose, like her A1Cs, and her kidney function. The ICD-10 code for this patient with type 2 diabetes with hyperglycemia diagnosis is E11.65. The EM code for her is 99214 due to the severity of the case and her signs and symptoms and the acuteness of treatment needed for this type of patient. Reimbursement for a nurse practitioner for this type of code is estimated to be about $92. Legal and ethical considerations with this case study is that about healthcare provider collaboration. The reason I chose this case study was due to the lack of collaboration with the nephrologist and the primary care physician to verify that the patient was properly treated for her diabetes and not to go with 2 weeks without a diabetic medication. So that is a big legal and ethical consideration that they took this patient's medications away but didn't replace it with anything else, and they did not collaborate together to verify that this patient wouldn't go into a hyperglycemia incident like she did with the blood sugar 544. Other considerations is continuity of care to make sure that the patient is continuing with her proper medications and that her all of her medical history is under control, like her hyperlipidemia and her diabetes and her chronic kidney disease, and to verify that none of these medications are going to interact and interfere, and that they have them all of her levels properly maintained with medications and lifestyle modifications, and to provide the best quality care and to practice with the ethical principles in mind. Those were drilled into my brain from years and many years ago, the justice, veracity, and just to make sure that you use them in every case that's brought to you, and just to make sure you practice within your scope of practice as a nurse practitioner. Here are my references. I hope you learned some valuable information and are able to take this out into practice now as future nurse practitioners. Thank you.